Welcome, and thank you for joining our conversation today around the COVID-19 vaccine. My name is Peter Chang, and I'll be your moderator this afternoon. My current title is Vice President of Care Transitions here at TGH, and I run our Clinical Command Center, which you see over my right shoulder here. It's kind of been the central hub for managing patient flow, especially in regards to our COVID-19 patients. During the next hour, we'll go over some of the latest information and updates around both COVID-19, kind of where we are from a numbers perspective. And most of the time will be spent covering the vaccination for COVID and really the community efforts around how we're trying to promote the vaccine and mainly get it out there into the arms of all the folks in our community. Many of our community members have submitted questions today. We've received almost 75 of those questions, so we'll be getting to some of those later today. You'll also have an opportunity to submit questions via the Facebook chat, so feel free to do so all at the same time. We have four panelists joining us today. Our first is Dr. Jason Wilson. The panelist is Dr. Seetha Lakshmi. She is our hospital epidemiologist and the director for our Tunisia Global Emerging Diseases Institute, and also an infectious disease assistant professor for the University of South Florida Morsani Health. And so Seetha has also been sort of the central figure in managing our COVID-19 effort in regards to how we're treating patients, coming up with our clinical protocols. She's really the tip of the spear when it comes to COVID care for our organization, and really has done an outstanding job in the last year. When we looked about 2 weeks ago, we had the anniversary of the first case that appeared in Washington State. So we've been at this for about a year, and we couldn't have done it also without Seetha's help. Our next panelist is Dr. Lucia Ramiro. So Dr. Ramiro and I go also way back. She actually taught me when I was a medical student here, and she's our vice president of our Tampa General Medical Group and one of our internal medicine doctors in our clinics. And she's really spearheading the vaccination effort for our patients and for the community members. So she'll give you an update about that also. And our final panelist is Adam Smith. He's our Senior Vice President of Ambulatory Services here at TGH, and he's really in charge of directing the strategy for all of the growth in our ambulatory division to really extend our footprint from a perspective of being out there for the community and providing care. And Adam's really also led that community effort, coordinated with the state for vaccine distribution, and you'll hear about that a little bit later. So again, we wanted to express our gratitude for you guys taking the time to hear us out today and hopefully get some of your questions answered. We'll start off with our first panelist for this afternoon, and we'll pass it to Dr. Jason Wilson to give us an update on our general COVID State of the House address and maybe what's going on in the community, and also give us an update on some safety measures that we can always reinforce.
Thanks a lot, Pete. And yeah, I can't believe it's been 16 years. And another thing, too, is I can't believe it's been almost a year into this pandemic, but it was almost a year ago that I was working a clinical night shift, and Dr. Lakshmi showed up in the middle of my shift. And I always joke, you never want an infectious disease doctor to show up to see an ER doctor in the middle of the night and say we need to have a conversation. It's usually not a good conversation. But we recognized that the cases were here in the area, and it was time to prepare. And really, this organization and institution, Tampa General and University of South Florida, have really responded and led and driven the response to this community going back now for a year. And I think that's why overall we've had the response we've had, which while obviously this pandemic has caused a lot of devastation, we've also helped mitigate and minimize some of that devastation too. thinking back to spring of last year, we were in the first phase of this pandemic, March, April, May, pretty low case numbers, and really spent a lot of time preparing, thinking about how are we going to deal with this virus, both at the hospital, this community, and for our patients. So learning science too, learning the medicine, learning how to treat and best care for these patients. And that really bought us some time to be ready for what was coming. And Pete, your leadership too, with the data dashboard and sharing data across hospital systems, all of that really bought us time and preparation so that when June, July, and August came, we were ready, because June, July, and August was really that first big surge that we saw. And that surge that we saw in mid-June was a surge of, our parlance is swab and goes. So a lot of younger people who maybe had contracted COVID from exposures at indoor crowded events, indoor restaurants, some type of party like a graduation party, or indoor, I call them closed box gyms, smaller gyms. So we saw hundreds of patients a day. We really doubled our emergency department volume. Again, learning from other sites, we had already stood up what we called an alternate care site, a place to deal with that volume of patients who were being tested for COVID in a different area other than with the emergency department itself. And we were seeing about the same number of people in that area with up to 30% positivity. So really high volumes of positive case numbers during that June, July period of time. In addition, during that period of time, we were able to start to stand up in the hospital procedures and elective surgeries and really start to think about, if this is going to be here for a while, if we're going to have to deal with this pandemic for a while, how do we get patients to the hospital safely? How can we deliver great emergency medicine care for patients who don't have COVID and for those who do have COVID? And we really saw a split flow model begin to take shape, where patients who were concerning for COVID, PUIs, which it really seems like everybody was at that time, were moving to different areas, depending on how sick they were. And then patients who had other things, that we of course want to make sure we provide great care of, strokes and heart attacks and needs for surgeries and traumas, they were moving to different areas of the department. So we hardwired that, really kind of leading up to that surge, and then really perfected that during that surge of June and July. Now, the other thing that was taking place too during that period of time with all those cases of COVID was that, as an innovative educational leader in this country, Tampa General was starting to participate in a lot of research and clinical trials as well. So both my team in the emergency department, Dr. Lakshmi's team on the inpatient side, we were starting to try to deliver the most innovative, strategies possible for these patients in terms of different antiviral drugs, and then also in terms of medications that might help some of the side effects of COVID, things like blood clots and other things people get when they have COVID. So we've really been able to give people, I think, the best care possible in this country when they do have COVID. And of course, testing high volumes of people for COVID, which is something we didn't see in New York and other places that sometimes have people on the floor for long periods of time, not knowing if they had COVID or not. We entered August, September, and October, and it was a little bit of a different flavor. A lot of the concern then was around schools, and a lot of that concern was whether schools were going to drive a community outbreak. It's interesting. Schools have not really driven community outbreaks. As a matter of fact, it's really the opposite. The community outbreak continues to drive schools. Now, college campuses are a little bit different, but fortunately, we got into September, October, and October, and a lot of our kids were able to go back to school. And overall, CDC just put out a report yesterday. Overall, things have been pretty safe from that standpoint. And our case numbers were not low, but were not what we saw in June. And so again, to level set where we were at then, very low case numbers, February, March, and April, very high case numbers, 100 times, 50 to 100 times the case numbers in June and July and the first part of August, then back down in August, September, but never back down to here. We were always sort of here. So about 10 times the case volume that we really needed to see to return to everything being safe. And then what we've seen most recently, November, December, and this part of January, is another surge, another explosion of cases, again, breaking some of those records we saw in June and July, but also much more complicated because mixed in with this were patients who previously had COVID, who are still suffering symptoms of COVID. Those are our long haulers, or people who need to come back to the emergency department or to the healthcare system multiple times. And then also patients who looked much sicker. A lot of patients who are having vertical transmission, meaning they are getting COVID from younger people during the holidays. So a lot of 75-year-olds, 80-year-olds, we call them twofers on the ER side of things. There's some inside baseball there. That means you walk in the room, you open the door, there's two people sitting in the same room. Usually that's a pediatric thing where brother and sister come in, but now it's grandma and grandpa when you open the door because they've both been exposed during a holiday event. And so unfortunately, that care is much more complicated and takes a lot more time. They're not swab and goes. We have to spend a lot more time with those patients. And that's really what we've been seeing post holidays. Now, the last week or so, we've seen a slight decline in that, which is great because it gives us a little breathing room and allows us to make sure we can continue to keep on developing that same great care for every patient, because it really does take some time to be able to deliver the best innovative care for each patient. And why is that? Because there are different treatments that require screening criteria to see if you need to go to research, to see if you need to get clinical treatment or be admitted to the hospital for that treatment, or go home with specialized biotechnology wearable devices, things that measure your oxygen level, things that measure your heart rate, and those type of things just take time to set up. And we need that time to be able to give patients the best care. So we're seeing a lot of patients home right now who we might have admitted back in June or July, but we're seeing them home safely. We're monitoring their oxygen levels at home, we're monitoring their vital signs at home, and then we're having them come back to our hospital, to the infectious disease area, and then our nurse practitioners, advanced practitioners are delivering those patients monoclonal antibody infusions, which have been a game changer since November. These monoclonal antibody infusions were really our first medication that had evidence behind it that we could give on the outpatient side, that we could give safely to patients who are not being admitted to the hospital. And so we've given hundreds of patients now monoclonal antibody infusions, and we've prevented about 70% of those patients from having to come back to the hospital. So a really big reduction in hospitalizations has taken place. Now, not everyone is a candidate for those monoclonal antibodies. You have to have some other diseases or be a little bit older, but people who are a candidate, we get them into treatment. And then some people just come back because they get sicker. And we recognize now a lot more about the clinical science of COVID. We know that 5 to 8 days into the syndrome, you may get sicker and may need to return to the emergency department. And then you may need to require oxygen. The requirement for oxygen is probably the number one reason we have to admit patients to the hospital. That's the thing we really can't do as easily for you at home, or we get scared, that you're going to be home if you need oxygen. Now, sometimes we can set you up for oxygen at home, but it also means that you may become eligible for other treatment modalities, things like the remdesivir you've heard about, or the Decadron steroids, and some other medicines too that help the pulmonary arteries and other viral mitigation medicines. So we're making those decisions constantly as we move into this phase. Now, the big worry we have right now is that obviously we've got a big event coming up in Tampa. We're all really excited about it. I've been a Bucs fan my entire life. This will be the second time they've gone to the Super Bowl. But what we really need is the help of the public to make sure we don't have another New Year's Eve style or holiday style type of partying atmosphere where we have these big crowds of people spreading COVID. So the NFL is working hard to set these events up safely. We've got to make sure as a public that if we're going to participate in these events, we do that safely. So you've heard it before, but it's the same old advice you've heard many, many times. Wear a mask, wash your hands, stay out of crowded, especially indoor crowded spaces. That is still important. Everyone's not vaccinated yet. So that's still the number one way to mitigate this virus. Thanks, Pete.
Great. Awesome overview, Jason. So informative. And just wanted to touch on a few of the points that you brought up. Really, also thank Jason for his community leadership and advocacy, both with the local, county, and city governments in the area to really help get things like, encourage masks, advise the school board on different items as far as starting back safely. So thank you, Jason, so much. But, Jason did touch on a few points, and some of the things we've done here at the hospital have really allowed us to have a declining mortality rate for our patients. So, as Jason mentioned, although we saw, very high numbers in the summer, right around the 4th of July, in regards to the total cases, in sort of the December time period here, we actually saw more cases per week in December than we did back in the summer surge. But our mortality was not as high; it was much lower. And patients did a lot better. I think that goes to just the medical community, especially here at Tampa General, knowing more modalities that work. When we started, everyone was talking about hydroxychloroquine or Plaquenil as a treatment modality. We now know that that's not as effective as some of the other therapies that we're using here at the hospital, and that's really a testament to the great collaboration and dedication to the patients in the community to make sure that they are getting the most up-to-date treatments, whether it's in regards to monoclonal antibody infusions with, I couldn't agree with you more, those really help our patients that get infected, prevent serious illness and hospitalization. And so that's a very important treatment for patients out in the community once they do get infected. But we'll touch a little bit more on hopefully some more preventative measures, as Jason mentioned, around masking and distancing and washing your hands and avoiding those large crowds, in addition to the vaccine. So with that, I'll pass it over to Dr. Lakshmi, who is our local and national expert on infectious disease. And Sita is going to talk to us a little bit more about how does the vaccines that we have right now from Pfizer and Moderna and Johnson & Johnson to be coming soon, how do they work? What's in them? And then sort of the current available COVID vaccines, and just give us an overall vaccine 101 class. All right, Sita, I'll pass it to you.
Thank you, Pete. So first of all, I wanted to thank the community that has joined in to listen in to the most up-to-date news. And it truly is a testament to all the hard work that we are today where we are today. And it's really great to see some of my partners in crime on this panel. To that, it's one thing to survive in crisis, but it's another thing to thrive. And that truly shows the team effort that is taken to be here. And just to be, the outcomes we have for our patients today with the USF Health and Tampa General collaboration, we are the top 20 in the country for the best care we provide for COVID. And that truly is possible because of all the hard work of the teams that are on the screen, but behind the screen and behind the masks today. The other big portion of it, I think that Dr. Wilson touched on, was the monoclonal antibody. And we have been truly, truly lucky in many ways to have some of the global talent in terms of innovation, especially on the research front with Dr. Kami Kim, and the clinic front with Dr. Oxner and Adam Smith's leadership and Dr. Ramiro's leadership, that we've been able to bring some of the research studies, including the region-run monoclonal antibody under Dr. Kami Kim's leadership, and to be able to make it happen without that key in from the research front and the clinical front, it would not have been even a possibility. And we were actually nationally recognized from Operation Warp Speed on how efficiently things are working with the monoclonal antibody clinic. We have still things to get better at as this pandemic has evolved. We've constantly been keeping up with the science and bringing the best care we can to the community. So having said that, the next frontier is here. It's the vaccines. It's an amazing time to be alive in terms of the science and the technology where it is today and what we're able to accomplish. And the vaccines today, I think the COVID vaccine in particular has shown us that how far we have come. Just to give you a flavor of the amount of vaccines that are out there. So there are the genetic vaccines, which is the one that you commonly hear now with the Moderna and the Pfizer vaccines, and also viral vector vaccines. It sounds fancy, but it's also a different delivery mechanism where you actually use a different kind of virus to give the immune system the trigger, like every other vaccine. And then there are killed vaccines, which is the more common ones that we're familiar with the influenza. So there's a whole flavor of vaccine, and there is a whole arena of different niche aspects to it. But I think beyond all those minor details, the big take-home point is that we have a safe and effective vaccine at this point. Will the virus evolve and have variants? We'll talk about it a little bit down the line. But at this time and point, we do have a very effective vaccine and a safe vaccine where all the steps that are necessary have been followed. There is a lot of questions that come up around what is this genetic vaccines, these mRNA vaccines, and you probably already heard some of the ways it works. So if we can share the slide that we pulled up in a second, it'll kind of show you the way it works. And the best analogy I have is kind of like a mailman analogy. The mailman comes to your home, drops the mail and leaves, right? So that's the point. The mailman does not sit and eat dinner with you. So it does not stay in your system. The mRNA components of it get destroyed right away. So what it does is essentially the mRNA comes and delivers the message, gets destroyed, your body gets the message, and it makes antibodies to fight against future exposures to that piece of the vaccine. Now, it does not deliver the whole vaccine, the whole virus. So it doesn't, your body does not have the instructions, the mail, if you will, to make a whole vaccine, right? A whole virus. So people don't get COVID from taking these vaccines. I think that's very important for people to understand that it's only very small portion of the virus that is instructed to be produced. It's only one particular piece called the spike protein. Beyond that, it also the platform of mRNA vaccines elicits a very good response. And for the future, it's a great mechanism if you see how vaccines will evolve in the future for efficacy, being very efficacious is a very effective platform. There are some other components to, understanding mRNA vaccine, and especially around, does it alter your DNA? And I think it's also very important to emphasize that DNA, God's genetic code that we all carry in us, is very stable and hard to destroy. Also, RNA has nothing to do with entering the DNA and changing it. So there is no changing of the DNA that happens. The RNA stays outside, makes the proteins it's supposed to, and gets destroyed. So there is no genetic changes associated with getting the mRNA vaccine. And then a few questions that often come about also revolve around pregnancy. And I feel very glad to be able to be here today and say that the American College of Obstetrics and Gynecology actually endorsed pregnant women getting the vaccine because, one, it's safe and effective, but also getting COVID as a pregnant patient is really, really devastating when it gets to be severe. Not everybody gets it severe, but when it does, it's 2 lives on the line. So those are some of the common things that happen, discussions around COVID vaccine. Also, in terms of side effects, we have given quite a few vaccines with Tampa General. I know Adam Smith is going to speak a lot more about it. And we truly had the ability to look firsthand on the side effect profile. And it's important to point out, with the number of vaccines that we've given, the side effect profile has been very, very favorable. If you look at nationally, the official review of cases, about 2 million vaccine doses review that was performed by the CDC noted, as you can see, anywhere between 0.2 to 0.4% side effects. That's a very small number of overall side effects. Most of the people, including me, that we've had vaccinations have had some sore arm. And on the second dose, especially, you do feel tired, may have some fevers. So those are the more common ones. Some uncommon ones, including increase in heart rate, have been noted. The most of ones that we've noticed here had resolved even before they needed to get any major medical help. And the last piece I'm going to touch on is around the variants. And there's a lot on the news around variants among COVID-19 virus. I want to take a step back, and I want the viewers to understand today that the reason lot of us going to infectious disease is that it's very moving. There's a lot of moving parts at once, and also there is evolution of the virus for its survival, and there is evolution of us for our own survival. So it's an intersection of those two survivals. So it's always a dynamic process, and that's kind of what you're seeing play out today in the global platform, is that the virus is trying to survive, and our bodies are trying to fight against it. So the survival pressure on the virus it'll always try to get better. It'll always try to get ahead. So far, what does that mean? We have seen 4 now notable mutations. The one B117, these sound like the electric car company performance, which is like, the numbers they give. P1 is another one that's coming from Brazil, and then the South African variant, and then one from Japan. So these are the 4 ones, and the scientific community is very closely watching the mutations because we will have to keep up with it, especially if it continues to have so much selection pressure to survive. Of the ones that exist, if we decrease the noise, right now, in terms of vaccine efficacy, it seems like for most of these, at least the 3 from the Brazil, the South African, and the London one, it appears that the vaccines will work. There might be some decrease in overall efficacy. However, because the vaccine is able to make so much antibodies, you still should be able to overcome the resistance, if you will. However, as everything with the pandemic, it changes very fast. Like Pete pointed out about the hydroxychloroquine, once it worked, and then we actually study it and doesn't work. So the same thing with vaccines right now. It appears that most of the available vaccines are going to work against the variants, but there are some that we have to really, really watch and be on top of it. And I'm going to close with the remark that no vaccine program, and this is Dr. Sinnott, who's been my mentor. He always says no vaccine program has stopped the pandemic. It's not a single vaccine will stop the pandemic. It's a good vaccine program. And that's kind of where we're going to in terms of getting the herd immunity and getting the vaccine. And then to Dr. Jason Wilson's point and Dr. Pete Chang, the vaccine we might still have uncertainties around the efficacy of the vaccine, but we know that the masks will work, the social distancing will work. So we definitely have to do a multifaceted approach. We do have to get to herd immunity with the available vaccine. We have to watch the variants, but also practice the things that we know do work at this point, including social distancing and masking with the Super Bowl coming up as well. I will stop there. Thank you.
Well, awesome overview of the vaccines, Dr. Lakshmi, and the great analogy of the mailman. I sort of use another one for the new mRNA vaccine that we have for COVID. It's the IKEA box. So you go to IKEA, you get this big box of something. You got to find a way to bring it home, right? Which is essentially the cell is your home. And the doctors and the scientists that designed it created the ability for that box to enter your home. And then you open it up, you unpack it, and you pull out a set of instructions. And those instructions is what the mRNA is. Your body uses those instructions to manufacture the small little tiny particle on the outside of the SARS-CoV-2 virus, the virus that causes COVID. And then it immediately sort of self-destructs that message, like Inspector Gadget, the message self-destructs. And then the particle is able to leave the cell, and the cell is not impacted in any way, shape, or form, other than we used its machinery to make more copies of that little piece on the outside of the virus. And then your body is able to form an immune response to that particle. So at any point in the future, if you're unfortunately exposed to the virus that causes COVID-19, then your body is able to surround it with antibodies and not become infected. So it was a great overview, Dr. Lakshmi. And then you sort of throw out the box and put it in your recycling bin, right, from IKEA.
It's definitely easier to read the instructions than IKEA one, I can tell you that.
Yeah, hopefully our bodies are better at assembling IKEA furniture than I am. So, but anyway, on that note, thank you so much for that very great overview. And we'll transition both Adam Smith and Dr. Lucia Romero, who help run our ambulatory services and our TGMG clinics. And we've really been on the forefront in getting that vaccine once we have the supply out into the community. So Dr. Romero is going to cover a little bit about who's eligible for the vaccine to date, according to the CDC guidelines. And then Adam's going to cover a little bit more about sort of the Herculean effort around vaccine distribution. We had the Pfizer vaccine here, and even the instructions on vaccine care and handling before we get it into the arm of a patient are extremely complex. In addition to the follow-up second dose, all of the other logistic aspects of administering this vaccine on a large scale. So with that, I'll pass it over to Dr. Romero and Adam.
So thank you. I'll kind of get started in listening to the IKEA story made me wish that for this vaccine, we had a IKEA instructions on how to roll this out, because it's definitely been a constantly evolving process. And so I'm going to take us back just a little bit. And as I was thinking about doing this talk today, I say we'd go back to the beginning, but the beginning was about a month ago. So it's in a month, we've really come a long way. So as Dr. Cheng mentioned, Tampa General was one of the first, they call them the Pfizer 5 in the state of Florida. So we were one of 5 hospitals chosen to get the initial rollout of vaccine. And the idea behind that was really, it was to test the system from, the federal government to the state to local governments into the hospitals. How does the supply chain work? How does the process work? And to really test the system. So on December 14th, again, it seems like so long ago, we received our first 19,500 doses of Pfizer. Our clinic started vaccinating immediately, and the clinic was set up to vaccinate our frontline healthcare workers, which include our physicians and staff that are handling COVID patients. And just to explain a little bit about, why is that? Why was that chosen? You hear a lot about, in other states and national news, you hear about the hospital beds and those really being I'll call it really a precious commodity. Well, think about having a COVID outbreak for the medical staff and those people taking care of the patients. Now you may have the beds, but you don't have the people to take care of them. So really that was the first line of defense, is get those frontline healthcare workers vaccinated. So by the time we got our first dose, we had already planned a rollout in the community with our other healthcare partners, the other healthcare providers. So within 2 days of us getting vaccine and starting our clinics, we were out at Advent Health, we were out at Baycare, Moffitt, HCA, and Bayfront, also helping them to vaccinate their frontline team members. So again, constantly evolving. After that first week, we were able to then transfer the doses to those other facilities so that they could finish their programs to get their frontline healthcare workers vaccinated, and also their second dose. Meantime, while all that's happening, we're continuing our clinic at Tampa General Hospital. Again, focused on our team members and physicians at first. We quickly expanded to include our frontline community healthcare providers who are not affiliated with a hospital system. Also, family members over the age of 65. So just, again, a constantly evolving process. We worked with USF, our partners, to help them start up their clinic in supplying vaccine. We work extremely close, and this is really important. It's really a collaboration. We work extremely close with Hillsborough County, our local Department of Health, led by Dr. Doug Holt, in the city of Tampa. And in the early stages, we allocated some vaccine. So this is just an example to show our relationship. in the early stages, we had allocated some of our vaccine to the Department of Health so they could get the community drive-through vaccination sites up and running. And then last week, they allocated us some vaccine. Again, it's just based on who has it, to be able to provide an opportunity for both public and private school teachers in Hillsborough County over the age of 65 to get vaccinated. And even today, we stand ready to assist with retired living communities in really working in collaboration with the Department of Health. One of the other things I think is really important for people to know is that this is a community-wide effort, not even just Hillsborough County, but we have a partnership. It's all 4 counties, so Pinellas, Pasco, Hillsborough, and Polk County. It's all of the local DOH, it's all the health systems, and it's everybody coming together as a region to really tell our story to the state of what are our needs and how can we get vaccination. And really what we're trying to show is, we have the systems in place, we are ready, and we are able to vaccinate as many people as we can. So we're really all in this together. And so that kind of leads us to a little bit of what's happening today. So you've seen a lot in the news about current allocations. So although we've had all of this planning in place, again, we stand ready to continue to vaccinate. The allotments coming into the state have really been less than what the state had anticipated and what, as a health system, what we anticipated. So most of the supply that's coming into the state now is allocated for second doses. We stand committed to anybody that received a first dose vaccination at Tampa General will be getting that second dose. So you've probably heard, some fear in the news and things about, well, I got my first dose, now I'm hearing it's scarce. Am I going to get my second dose? We are absolutely 100% committed to that. So the supply that's coming into the state is being really driven to the public's initiative. And the governor's point in doing that is really to get multiple access points for people. And then the other one that you'll hear a lot about is the mass drive-through vaccination sites. So those are being set up throughout the state. They are able to do, anywhere from 1,500 to 2,000 vaccinations per day. And if you ask my opinion, what is the right answer? How do we get that vaccine out there? It's kind of a yes and. Publix and these mass drive-through are one avenue. And I also think the hospitals and the health systems and healthcare providers provide another crucial avenue. Right now, there's just not that amount of vaccine coming into the state to be able to have all of those, really live and running. But we stand ready. All of the planning is in place and continue. So we vaccinated just through the Team Member Health Clinic over 15,000 people. Both our providers, the teachers that I spoke about. And so there's a lot of questions about where can people get vaccinated. So if you could pull up the first slide, here are some current locations that I'd recommend for people to make sure that they stay and have the most current information. So the Hillsborough County website, they have a COVID-19 vaccine page. And basically, this will give you all the information because this is a constantly evolving process. The more vaccine we get into the state, the more access we'll have, the more access points. So this is one point of contact that you can go to for the latest information on where to get vaccinated, how to get vaccinated, and who qualifies to get vaccinated. If you can go to the next slide, Tampa General Hospital also has a www.tgh.org/COVID. This is a coronavirus hub, and it's really a great resource for all information COVID related, whether it's vaccine, the COVID testing, and any of the distribution, the antibodies that we talked about, the infusion. So it's just a good one-stop location for information related to COVID and to any of the coronavirus vaccines. One of the things that I just wanted to transition to, on December 29th, so again, that was less than 2 weeks after Tampa General received its initial allotment of vaccine, we set up through our Tampa General Medical Group, the primary care clinics, the ability to vaccinate the patients within their platform over the age of 65 and those immunocompromised. So with that, I'll turn it over to Dr. Romero to talk more about those initiatives.
So thank you, Adam. And it truly took a village to get our vaccine program up and running. So special thank you to our IT team and to our operation teams who spearheaded our program. So as what Adam said, we began our vaccine program right before New Year. And consistent with our governor's executive order, we started with patients 65 years old and older. There was a great demand for the vaccine. It was amazing. So right after the holidays, we decided to close our Armenia primary care office and dedicated the whole place just for the vaccine program. Then we quickly ramped up and we were vaccinating around 350 patients a day at our Armenia location. And then to provide additional access for our underserved patients, we also provided COVID-19 immunization at our Health Park Primary Care Clinic. We opened access to patients less than 65 years old with risk factor last January 11. However, on January 15, we temporarily paused scheduling first dose vaccination. We also had to cancel patients already scheduled from January 18 onward until we hear more from the state regarding supplies. So in total, we have given almost 4,400 first dose immunizations at our Armenia and Health Park locations. Currently, we are only giving second dose vaccination for patients already scheduled. Now, Pete, you talked about rollout from the CDC. They kind of recommended a phased rollout. Again, it will still be dependent on the state how to do this. But according to the CDC, for the phase 1A rollout, you start with healthcare personnel, and I think Adam already explained why. And they also recommended to give immunization to long-term care facility residents. And after those patients, then you go to the 1B, which include frontline essential workers. And these are just some of them, like firefighters, our police officers, our mailman. By the way, Dr. Lakshmi, I love that mailman analogy. We also talk about even our grocery workers, those that work in the transportation industry. And the CDC recommended patients who are 75 years old and older only because they're a higher risk for hospitalization, illness, and death from COVID-19. Then after that is 1C. These are patients who are 65 years old to 74 years old because they're, again, at higher risk for hospitalization and illness. Also included in 1C are patients who are 16 to 64 years old with underlying conditions that put them at high risk. And after also included in the 1C are those that works in communication, workers that works in communication, energy, information technology. And those are the CDC recommendation. And again, it's up to the state to decide how they want to phase in their vaccination program.
Great. Thank you so much, Dr. Romero and Adam, for that great information. And both of you have done an outstanding job in rolling out this vaccine into the community. So I guess another good analogy of describing it is you have, the passenger jet ready to go. All you need is the fuel,
Right.
You just need to be able to fill up, and that's the vaccine that we're missing, but it's nice to know that the infrastructure is there, that when we do get our allotment, we have a way of turning it back on and getting all of those patients that were canceled, and really trying to partner, as you mentioned, Adam, with our other health systems, with the private sector companies that you mentioned, to really come together and figure out a good way to get the vaccine in the arms of our community. It's a good thing right now. I know there are a lot of questions about the vaccine, which we'll get to, but it's a great thing that more people want the vaccine than we have a supply of it. So that means that as soon as we get our supply, and that should be shortly, we don't have an exact time frame, but as soon as we get it, we'll be able to start getting it out. So those resources that Adam mentioned, we want to make sure everyone continues to go back and revisit those sites frequently for the latest updates and news on how you can get access to the vaccine once we get our allotments in. All right, so we've a couple minutes over, but we still have close to 20 minutes to get some of the questions answered. And so we do have about 5 or 6 questions that were submitted before this event. So let's start off with the first one, and we'll just open it up to the entire panel. So just make sure you're not on mute so we can hear your response. But the first question is from Mary, and she says, once you receive the COVID-19 vaccine, can you still contract coronavirus and spread it to other people? A great question, Mary. Sita, this sounds like one down your alley.
Yes, I'm glad you asked that question, Mary. As you know, there's a lot that changes with this every day. In fact, every time a virus infects a person, there's a lot that changes in the virus and the person. So in both those fronts, we're trying to figure out what that means for the future. If you look at historically, when we make antibodies, and diphtheria is another example of an infectious disease organism where you make antibodies, but that doesn't mean that it'll protect you as a person because you make the antibodies, but your mucosa in the nose and the mouth doesn't mean that it will still be able to get rid of it from transmitting. So you could theoretically be able to transmit. We don't know the full spectrum of it. I think as we move forward, we'll get a lot more answers and understand it a little better. But until we know further, and the fact that our cases are so high right now, it'd be really prudent for people who have been vaccinated, who have a good antibody response, still to continue wear masking for those reasons. One, that you might still carry it and not know, and God forbid, give it to your loved ones. And the second thing is the variants. So the new variants that are coming up, we're still learning how much the existing vaccines work. If you look at Moderna and Pfizer, they've kind of already started gearing at making those vaccines more targeted towards the variants as well. So until we know more on the variants and the transmission, it would be prudent that we continue to wear masks and assume that we transmit until we know otherwise.
That's a great point, Sita. We know that, again, you form antibodies whether you were previously infected with COVID-19 or if you receive the vaccine. Now, if you're exposed again to the same strain or potentially a different one, that's really Dr. Lakshmi's point that there's a possibility that that virus can get into a couple of your cells. And once it gets in, it just makes copies of itself until it eventually kills that cell. We also have to remember sort of the mechanism of illness is really you don't get sick from the virus itself, you're getting sick from your body's reaction to seeing this virus and that inflammatory response that your body gets. So most of the therapies around treating COVID-19 have revolved around trying to modulate that immune response that's formed. But great point, Sita. And I think you also may have answered another one of the questions as we were rolling through this. We did have one come across our Facebook Live, which is how are we tracking our vaccine side effects? Sita, you talked a little bit about some of the numbers in regards to who's having side effects or any reaction to the vaccine. Is there a place that people can go to access resources, or is this recorded on any database?
So another great question. There is even before COVID, there has been a vaccine adverse event reporting system. So all the sites that are giving you vaccination right now are required to report vaccine adverse events reporting system. It's called VAERS. And that's how we actually know. When I mentioned, they've reviewed 2 million people who already got vaccine and what side effects, that's how we know, because we track. So that is a formal process as well. So yes, please, report to the site where you had the vaccine to let them know if you're having side effects.
Great, thank you for the update. We have another question from Heather, and I think we've touched on this, but I just want to make sure we give a good answer. Heather would like to know what advice you have if somebody recently had been diagnosed positive for COVID-19. Should they get the vaccine? And does a COVID positive person have immunity, and for how long?
Yeah, so Dr. Wilson and Dr. Ramiro, feel free to jump in. I know you see a lot of the spectrum as well. It really depends on the person's ability to make antibodies, right? So what we know so far is that natural immunity does give you some protection. In fact, under Dr. Kim and Angie's leadership in our lab, we're looking at how different people respond to antibodies and looking at their titers. But that's really in the cutting edge. But from what we know so far is that with the first infection, natural immunity seems to help you protect yourself most robustly for the first 90 days. Beyond the 90 days, it appears that the immune system does wane a little bit, and depending on how robust your immune system is, you may be susceptible to reinfection. All the rates are low, severity is low. These things might change as the variants, start coming into the picture. So based on that basic understanding, the recommendation right now is for the first 90 days, you're probably protected from your own body after an infection from getting reinfected. So based on that, the recommendation from CDC has been that you wait 90 days until you get your vaccine. There's a little bit of a difference for healthcare workers, especially based around, how we look at transmission. So for healthcare workers, there has been some guidance as to if you want to get a vaccine earlier, yes, please go ahead. They're a vital force along with other essential workers as well in the front line. But for everybody, it's 90 days, you're still likely protected. And then after 90 days, get the vaccine.
Great, thanks, Sita. This is a very insightful and interesting question from Nadia. She writes, any correlation between the COVID-19 vaccine and an increased risk in forming blood clots?
Yes. So Dr. Wilson, I believe, also has a lot of insight into this. I'll start off and hand over to Dr. Wilson. It appears from what we know of what the virus does to your body, like Dr. Chang mentioned, the beginning part of it is your immune system trying to, just limit it, like stop, right? When it gets past that wall, then the immune system really has to rev up. And when the immune system revs up, like a car just revving up, heat goes up, so you're super febrile, and then also you dehydrate, right? That means your blood gets a little thicker. That means it doesn't move as well and you form clots. There have been different studies that look at what can we do to prevent. More data is forthcoming on this, but definitely until at least 6 to 8 weeks after the acute infection, you would be at a slightly higher risk for clotting, leg clots, strokes, heart attacks. And those are the devastating complications we want to avoid. Right now, we do recommend, at least aspirin after, at the very least, if you're lowest risk. But this is a discussion you have with your doctor and say, these are my conditions. I have COVID. Do I need to be on anything for preventing strokes or clotting? I'll stop there. I know Dr. Wilson has a lot of insight and Dr. Ramiro as well.
Sure. The one thing I would definitely add is that the vaccine itself does not have any evidence of doing any of this. So the vaccine is safe, and we have not seen any evidence the vaccine causes any clots. So let's make sure we're talking about virus and then vaccine. Now, the virus itself, like Dr. Lakshmi mentioned, we think that the clots likely come from the body's response to fighting the virus itself, the body's defense response. So in fact, some recent data just came out that people who are really sick with COVID they didn't get as many blood clots as people who were kind of sick with COVID, probably because people who were really sick weren't able to fight off COVID as much as the people who were kind of sick. So we are worried about blood clots in people with COVID, and we do have a big trial at Tampa General trying to prevent those blood clots from happening. But we don't see that with the vaccine. The vaccine is safe.
Great. That's a really, really great question. And thank you, Jason, for differentiating. You think about how a blood clot forms. If we all know, if you had in the kitchen and had a knife slip and cut your finger, right? Immediately, inflammatory mediators go to that site and start to turn on blood clotting so you don't bleed out. So it's the body's natural defense mechanism of doing that. Now, when you have an active COVID infection, right? Those inflammatory markers, some of the similar ones that happened in the example that I said of cutting your finger, start to activate without any cut, and it's inside of the body, and where the blood doesn't flow as quickly. That's usually where in those places where those blood clots form, and that's only an active COVID disease, as Dr. Wilson mentioned. We haven't seen any increased clotting risk with the vaccine. So I think that's an important note. Remember, that vaccine just delivers the payload. Your body reacts, creates that antibody to that protein or the little dot on the outside of the COVID virus, and then it's gone. And then your body just continually makes more antibody as time goes on, which sort of leads to the next question. Do we know, this is from Pamela and Rebecca, do we know if there are any studies on how long some of these antibodies last for COVID-19, whether it's in respect to previous infection or now the vaccine? This is a very popular question, and I think one that's a little bit hard to answer at this point because we just haven't had enough time, but I'd like to get your thoughts.
I don't think we know yet. Studies are still ongoing. I think the first patient, I think Dr. Lakshmi, is it July last year that they started some of these studies? And I think we're continuing to follow what's going on with those patients that were studied early on.
Yes, I completely agree. I don't think we know. And also to emphasize, our immune system is not just the antibodies. There are also like the antibodies are like the bullets, but the immune cells are like the soldiers. So you have both. And how long it appears from the vaccine trials themselves, when they're looking in the beginning phases, that there was the memory cells, like the soldiers that remember the long term, so those were activated, and they tend to have long-lasting effects on the immunity. So there is a lot of hope based on that mechanistic understanding of it. But in reality, in real life, what does that mean? Does that mean you're going to be protected against the variants? So a lot of things we don't fully understand, especially around the antibodies and the cells themselves. There are two different things that work. So we have to wait and see. I know, Dr. Wilson, if you heard anything else.
I think that's actually right. And the other side of that coin is always, am I have to get another shot someday? Am I have to get another vaccine? And look, the answer is I don't know. But I will say this new technology, this mRNA technology, is really exciting because it's almost like an app on your phone where you can kind of keep all the hardware and everything the same, but change the app itself and kind of re-download it, and you get some benefit. And so perhaps if we do, we just kind of change some things in the mRNA, the instruction booklet, and build a different IKEA chair in the future.
Great. Thanks so much. Great input. One of the last questions we have really quickly is folks that are immunocompromised in some way. So whether we're transplant patients or patients with autoimmune diseases like rheumatoid arthritis, is it safe for those type of patients to get vaccines?
So we do have, Moffitt and Dr. Green that actually has worked very closely with those immunocompromised patients and also in the infectious disease team at Tampa General and USF. So a collective understanding of immunocompromised patient, I think, still needs to be forthcoming. We still need to understand, in terms of when is it, booster, how much, and all those in its entirety. But right now, at this point in time, if you're talking to somebody who's immunocompromised, they really need to get the vaccine when they are able to get it, because in the immunocompromised population, getting COVID, it's very devastating. So right now, unless, three caveats, unless if you're getting active chemotherapy and your neutrophil counts are really low, then you talk to your doctor and say, yes or no, let's wait. The second thing is if you just got a bone marrow transplant or the CAR T therapy, those are very specific. But beyond that group, you have a discussion with your doctors and they'll be able to guide you. But the guiding principle here is that if you do have an immune deficiency, you definitely should be getting the vaccine, but have a discussion with your doctor around it. Dr. Ramiro or Dr. Wilson.
Well, I know we're at time. We'll probably spend another minute or so wrapping up. Really great information today, and it has to go with one of our disclaimers. Anytime we do, give some advice or spread some information, we have to remember that we're still learning every day. So you kind of heard the latest from everyone, but please take that into account. And if you do have any questions, make sure you consult your primary care physician to discuss, any nuances of your own care. And again, I just want to thank the audience out there and for our four panelists for really having a very informative discussion on both where we are with COVID in our community and also a little bit more about the vaccine. We'll encourage you to please visit tgh.org. And go to the coronavirus hub that Adam Smith mentioned to stay up to date on the latest news regarding COVID. And it would be remiss if I didn't close out by saying go Tampa Bay Buccaneers. And we hope that the area gets to enjoy a win in early February. So thank you all again for attending today. And we look forward to your chat. So please do post in the Facebook chat if you have additional questions, and we can hopefully answer some of those as we go along. And if there's any additional links, we may post them there also. Thanks, everyone. Have a great afternoon.
Thank you.